Thank you for having us here to share some information on the draft local coverage determination for DecisionDx-Melanoma. I'm Frederico Monzon, Chief Medical Officer for Castle Biosciences, and Derek Mitchell, our CEO, is back there. This draft LCD is an expansion of coverage. This is the coverage criteria. The test has been previously covered for only guiding sentinel biopsy decisions. At this point, this LCD expands the coverage for guiding all of the decisions that are used in patient management in melanoma. This comes under strong clinical use of the test. We have tested 40,000 patients so far, over 40,000 patients, and just in the last 12 months, over 3,200 physicians ordered the test. So this test is used, as I mentioned, to determine the risk of the patient, the risk for metastatic disease, and this risk actually informs all the decisions that physicians make when they're doing when they're managing a patient with cutaneous melanoma. It helps them determine whether this patient needs or not a sentinel biopsy. It defines how often and what type of imaging modality they're going to be using, and it also helps them determine how often they follow up, whether they need to refer to other care members of the melanoma team, and in some occasions whether this patient benefits from adjuvant therapy or not. The test is basically a gene expression profile based on 31 genes, and goes through a validated algorithm that classifies patients into class 1 and class 2. These two groups have different prognostic. Class 1 is a low risk, class 2 is high risk, and then these are subdivided further into 1A, 1B, 2A, 2B, with 1A being the lowest risk and 2B being the highest risk category. The problems that DecisionDx-Melanoma test addresses are two, and they can be summarized on this graph on the left. Basically, the majority of patients who die of melanoma, who presented with localized disease, present at stage 1 or 2, which signals that our staging systems that we use today are unable to identify a large proportion of these patients that end up dying of melanoma. We classify them as low risk because they're early stage, but hidden in that low risk early stage is a group of patients who have high risk disease, which is biologically high risk disease, who end up contributing to the majority of the mortality in this group of patients. The other part is that those stage 1 and 2 patients are actually what we classify as sentinel biopsy negative. So these patients are from this group of sentinel biopsy negative patients, meaning, again, sentinel biopsy, this procedure that is a surgical intervention for staging only, actually misses a lot of these patients. We see that 2/3 of the sentinel biopsies of the patients who undergo sentinel biopsy, or the patients that die, are in the sentinel biopsy group, and these patients derive no benefit from undergoing this surgical procedure, and they are subjected to the complications and the anesthesia risk of those. And then, with anatomopathologic staging, again, we miss the great majority of patients that die of melanoma, and it's a system that actually has significant discordance in staging of patients alone. So the failure to identify this risk of patients to develop metastatic disease leads to under and over treatment of patients in melanoma. And these patients obviously have the right for the right treatment at the right time. So what the test does is actually it adds additional prognostic information to each of these staging or to our staging system. So when a patient has a defined risk based on the staging that they present, the test actually adds additional information. So we see here class 2B patients consistently, depending on the stage, have a much higher risk than what their anatomopathologic staging would say. And the same can be for class 1A patients, where you can see how much lower the risk for those patients is for developing metastatic disease, or actually in this case is from dying of melanoma, which is what the staging system uses. And you see that even patients that by staging would be classified as high risk based on our current criteria, they can actually be moved to the low risk category, as well as vice versa. Patients who originally could be low risk actually can be moved into the high risk category, those allowing to better estimating the risk for these patients. And what this allows us to do is to answer this question, is whether a patient needs a sentinel node biopsy, or how should we follow up this patient based on these follow-up imaging and referral instructions. And then low risk and high risk patients go into very different care paradigms that the test helps inform how to do. There has been a significant number of publications. We have over 20 peer-reviewed publications with over 3,100 patients studied in the validation and performance study, prospective study, clinical impact study, as well as a recently published systematic review of the literature which support the use of the test. I'll quickly go over a couple data points here. This is the study that supported the use of the test for sentinel biopsy guidance. As you can see here in the Medicare population, you can see over 65 years old, patients who have a class 1A result have a 1.6% risk of being node positive. So the majority of those patients who are class 1, over 65 years old, and belong to the T1, T2 group are going to be negative. So the test is identifying these negative, these patients who are at very low risk of node positivity, and therefore these patients actually can avoid the surgical procedure. On the other hand, the patients who are actually at high risk for node positivity can be identified by removing those low risk patients. Not only that, these class 1 patients actually show excellent outcomes, so you're not harming them. There's no harm by removing the sentinel biopsy procedure from this group. And this is the paradigm then. If you have patients who are T1, T2, sentinel biopsy eligible, by using the test, you can then determine that class 1A patients can avoid that sentinel biopsy procedure, and that helps to avoid unnecessary procedures in those patients, focus the resources of those patients at high risk the resources on those patients at high risk for recurrence, and increase the yield from this surgical procedure, as well as reducing healthcare costs. The other part of the test, the prognostic beyond the lymph node biopsy, is actually supported by multiple studies, as I already mentioned. This is just a visual to see the consistency of the studies, both archival and prospective, independent and Castle-funded studies. They all show the same thing. Class 1 patients do very well. Class 2 patients are the ones that are high risk. And that is actually summarized in this paper that just came out earlier in August this year by Dr. Dubin, Deinhardt, and Farber, which reviewed the published evidence and concluded that the results of these tests may help guide the frequency of skin examinations, utilization of sentinel biopsy, and imaging. So they looked at the literature in total and have shown that the evidence out there supports the use of the test in all these areas that they're mentioning, and therefore supports the expanded LCD. The last piece I wanted to touch base is the appropriate population for testing. So this is one of the things that is incorporated in the LCD, and this is a publication that went on to look at the question on how thin is a melanoma to actually be eligible for the test, or where we can actually provide actionable information for that test. So because when we look at thin tumors, these are only thin tumors going from 0 to 1 millimeter thin, and you see that overall the risk is very low. So one could ask the question, is there any benefit from doing the test on this group? Because if you look at class 1A patients, they do have a lower risk, but it's a reduction in risk that one might question whether it's clinically useful. The importance here is that we can find class 2B patients in these two groups, and you can see the risk of recurrence in these patients is much higher than one would expect based on their anatomic pathological staging. What's important is that we can find a threshold at 0.3 millimeters of thickness where we don't see any events happening. So, in this population, less than 0.3 millimeters, Well, the test it would not add any information because we don't see events in that population. But beyond that, the test can actually find patients who have very different recurrence risk. You know, whether you look at all recurrences or distant metastatic recurrences, you see that the difference between a class 1A and a class 2B patient are strongly significant. So this is where it adds, and this threshold of 0.3 millimeters as the right patient population to test and not do over testing is something that has been incorporated in this updated LCD. So just to summarize again, if we look at the melanoma patient population in terms of managing patients for follow-up, referrals, use of imaging, any patient over 0.3 millimeters are actually eligible or is the appropriate population for test. And then for guiding sentinel biopsy in this patient population, we can look at a subset of these patients in which the test can help guide the sentinel biopsy procedure and the decision to undergo this expensive surgical procedure. So with that, I'll just conclude that we do support this draft LCD. We recommend a language change, as well as we'll submit our comments for some additional minor changes. But there's a text that says that DecisionDx-Melanoma is not covered in patients who are not seeking disease-modifying treatment for cutaneous melanoma. We believe that this could be misinterpreted as only those looking for pharmacologic treatment. So we suggest a change in the language in which the test is intended for patients who are, the test is not covered in patients for which the results are not intended to guide treatment and management decisions for cutaneous melanoma. Just a slight change that clarifies that it doesn't need to be pharmacologic treatment. And with that, I will stop here and take any questions.